Okay, thank you for this invitation in this educational activity. These are my disclosures. And we're going to discuss a clinical case of a 70-year Caucasian MSM, recently diagnosed of HIV, who is referred to our HIV clinic. He hasn't used pre-exposure prophylaxis against HIV. He's non-smoker, he hasn't used chemsex, and he has hypertension, hypercholesterolemia, and a benign prostate enlargement. Both are treated with drugs. He had a primary syphilis 4 years ago. He wasn't offered pre-exposure prophylaxis in that time, and his body mass index is 25, so he's in the limit with overweight. And he, in addition, receives gabapentin for unspecific back pain and omeprazole, despite he has never proven any peptic ulcer disease. And he also receives trazodone once daily for intermittent insomnia. Due to his age and his hypertension and hypercholesterolemia, he has a high cardiovascular risk at 5 years. In the Framingham score is 30%. And regarding the HIV, he has 190 CD4 cells. The viral load is 79,000. And the HIV the genotype is wild type, subtype B. And all the screening is only relevant for chlamydia trachomatis in the rectal swab. He's been treated with doxycycline, and all the study of HIV is normal. He has immunity against hepatitis B and A, and the remaining things are normal. He's ready to start antiretroviral treatment. So what do the guidelines recommend regarding initial antiretroviral treatment? As you can see in the 4 main international guidelines, there's a high concordance nowadays. Well, they recommend a treatment based on an integrase inhibitor, either bictegravir or dolutegravir or raltegravir. For the first time in an international guideline, the EAS USA guide does not include Triomec as a first-line treatment because they remove it due to the association of abacavir with cardiovascular risk. It's the first time it has been removed as a first option in initial treatment. You can see as well that a 2-drug regimen composed of dolutegravir and 3TC is recommended as well, with some caveats. Viral load must be below 500,000, no hepatitis B, no transmitted drug resistance, and in some guidelines, they also recommend a CD4 cell count above 200 cells. Well, that is okay, but what about people with high cardiovascular risk or people aged like our patient? There are no specific recommendations for this scenario. There are some scenarios with a specific recommendation in the guidelines, like tuberculosis, a pregnant woman, but nothing regarding high cardiovascular risk or an aging patient. The question is, do all the people have different biologic outcomes in research clinical trials with regards to the age? Is that important? You can see the information we have with dolutegravir 3TC, dolutegravir plus 2 nukes, either tenofovir or abacavir, and bictegravir FTAF. And as you can see, this has been assessed in all the trials, and age has no impact in the biological response with any one of these treatments. The patients are split with ages below 35, 35 to 50, or beyond 50 at 1, 2, or 3 years in all the studies, and there's never difference regarding to age. So overall, these data make a very compelling case for similar antiretroviral efficacy, particularly biological and immunological efficacy as well in all the naive adults, if we accept adults as more than 50 years. That's a problem because aging characteristics really start at 65 to 70 years. The problem is that we have a low number of patients above 65 or 70 years. And so usually the analysis cut at 50. Beyond 50, not everyone has biological characteristics of aging. So sometimes we have a limited information regarding this association between aging and virological efficacy. Okay, that was research clinical trials. What happens with cohorts? This is the response international multi-cohort collaboration regarding the efficacy of initial antiretroviral treatment. It's more than 5,000 naive people since 2012, and they analyzed a composite endpoint outcome of treatment, which is defined as success in virological response below 200 copies, with no regimen change and no disease progression. They also analyze specifically virological, immunological, and clinical response. So they have four endpoints or outcomes in the analysis. As you can see here, the age does not significantly, these are p-values, age does not significantly impact any one of these responses. So the composite endpoint, treatment, virologic success endpoint, immunologic success, or clinical progression. So again, putting the limit in 50 years, no one of these outcomes is influenced by age. That's good. Uh, let's see some general considerations regarding aging people living with HIV. It's considered very important in older people to start as soon as possible antiretroviral treatment because they have greater risk of serious non-AIDS complication and they can have a jeopardy of the immunologic response. Adverse drug events are usually more common, particularly in the bone, kidney, metabolic, cardiovascular, cognitive, or liver adverse events can be more frequent than in young people. And obviously, they have more diseases and they have more polypharmacy and the frailty syndrome. All this burden of age-related diseases is significantly higher among older people, both HIV and non-HIV infected. And it looks like in HIV infected people, this comorbidity is more frequent than in non-HIV infected population. And regarding these comorbidities, the most frequent ones are hypertension and hypercholesterolemia. As you all know, it has been suggested that HIV units or ID services should have a focused approach to deal with all these comorbidities in HIV-infected population. Our patient has 190 CD4 cells, so he is a late presenter. Late presentation and a more severe disease and diagnosis is common in older people with HIV, and it's simply related with the lack of awareness of healthcare physicians. So there's a low index of suspicion regarding the potential HIV diagnosis in older people, even if they have suffered indicator diseases like bacterial pneumonia, herpes zoster, anemia, lymphopenia, or thrombopenia. So we have to be aware of the potential diagnosis of an HIV disease, particularly in people with indicator diseases or risk sexual practices. These are missed opportunities for earlier diagnosis. This is the median age population of the cohort since 2015 in the US, in the veteran aging cohort study. They have two peaks at 30, 35 years, and the second one at 50 to 60 years. So it's not uncommon to diagnose people between 50 and 60 years. And as you can see here in the graphic with colors, as the age increases from 40 to 50 to more than 60, the number of people with AIDS at diagnosis, a CD4 cell count below 200 cells, or any AIDS-defining illnesses increase paralleling the age. So once they are diagnosed, it's not uncommon that they have late diagnosed and any disease indicating AIDS. What about the polypharmacy? It has been discussed in this workshop. Older people have obviously more comorbidities than younger peers, and they receive more polypharmacy. Some medications are unnecessary. That's very common and must be deprescribed, so must be stopped. So it's not only looking at potential drug-drug interactions, but reviewing all the medications to see if some of them can be stopped. They have an increased risk, obviously, of drug-drug interactions and also a potentially clinically relevant drug-drug interactions, which are not common despite the high number of drugs. Really clinically relevant drug interactions are uncommon, below 5 or 3%. So systematically, it is recommended to avoid boosting with ritonavir or cobicistat or using any CIP inducers like efavirenz or any other drugs. The most common medications in the veterans aging cohort in the year 2018, in the last analysis, this has been just reported now, were antihypertensives, 70% lisinopril, amlodipine, metoprolol, antilipemic agents, 51%, statins mainly, antidepressants, 38%, non-opioid analgesics, and non-steroidal anti-inflammatory drugs. These are the drugs more commonly prescribed in older people. This is real life, but what happens in clinical trials? As you all know, in clinical trials, usually people with a high polypharmacy are systematically excluded. So they are not a good representation of real life in older people. But in the development of dolutegravir, this is a meta-analysis of the studies ARIA, Flamingo, Single, and Spring 2 at 48 weeks, with a very high number of antiretroviral naive people with HIV. And here we have information of people with more than 50 to 65 years with a relevant number of patients, and people with more than 65 years, or obviously with a more limited number. What we can see is that in people with 50 to 65 years, those who were not using medications in green was 25%. So only 1 in every 4 patients is not using any co-medication. In orange, you can see that 44% are using less than 5 medications, and 31% are using more than 5 medications, even in a clinical trial where some of these people could have been excluded in the recruitment. The rates of comorbidities in these participants receiving dolutegravir or the comparator non-dolutegravir regimen, as you see again with the colors, the rates of comorbidities increase with the age, but not every one of them. Here you have grouped by cardiac diseases, gastrointestinal ones, metabolism and nutrition, nervous system, and psychiatric diseases. Only cardiac diseases with group hypertension and ischemic cardiopathy and all the cardiac diseases, and metabolism and nutrition, which groups hypercholesterolemia, diabetes, and all these diseases. These are the 2 kinds of diseases that are typically increased in older people in a linear way, as you can see in less than 50, 50 to 65, or more than 65. The other diseases, the incidence are not increased in older people. The risk of polypharmacy and inappropriate prescribing in older people, in this case, again, more than 65 years. This is an analysis of more than 100 people in the University of New Mexico in the US. All they are HIV infected. 87% had HIV suppression, below 20 copies, so full biological suppression. And polypharmacy was defined as usually 5 or more co-medications associated with antiretrovirals. The average of polypharmacy was 12 drugs, including 9 non-HIV medications. 98% so met the criteria for polypharmacy, 5 or more medications. They used 3 international score criteria, the BIAS, the STOP, and the STAR criteria. And these are good scores because they not only monitor drug-drug interactions, but drugs that should not have been prescribed and the subject is receiving, and as well, drugs that should have been prescribed and the subject is not receiving. Typically, the subject has not been vaccinated against pneumococcus, has not received the influenza vaccine, or is not receiving vitamin D or proper antihypertensive or statin therapy. So that's also very important. So drugs that should have been prescribed or that are not used at the proper dose. In the STOP criteria, drugs that the subject is receiving and should not be receiving, and then drugs that can cause drug-drug interaction with the medication that the patients are receiving. These are the rates of patients with at least 1 prescribing error with any one of these scores. And as you can see, they range 50 to even 80% in some of them. So it's very common, and it's very important to review all the polypharmacy of all the HIV infected subjects. An important field is the weight gain in HIV infection. As you know, it's associated with the exposure to dolutegravir, bictegravir, TAF, and some other regimens. It's a multifactorial disease, so it's not only the drugs, many other factors like the race, the gender, but it's common. Is age a risk factor for weight gain? That's a very important question. We have many sources of information. One of them is the brilliant analysis from Paul Sachs from 8 research clinical trials randomized of initial treatment with more than 5,000 participants and 2 years of follow-up. And the risk factors for any weight gain were being younger, a greater weight increase, having a low CD4 cell count, black race, intravenous drug use, or a high baseline HIV RNA, more than 100,000 copies. They were strongest predictors of weight gain, but there were no differences in weight gain by age in any of the stratification they did. So age was not identified as a risk factor for a weight increase. That's important. This is another analysis, in this case, a retrospective cohort coming from the US, done by Grace McComsky, and they try to identify in an adjusted analysis the factors associated with weight gain in a switch from TDF or abacavir to TAF. And as you can see, everything is completely concordant. Age below 50 was not associated, so age overall was not associated with weight gain. What happened with our patient? Let's go back to the patient. We reviewed the treatment, the relationship with polypharmacy, which is very important. It has been treated in the present activity, the late presentation, and the relationship with weight gain. Our subjects started the formulation BKFTAF. Diet and exercise were advised. The statin, simvastatin, was changed to atorvastatin, 20 milligrams once daily, which is the dose for this subject. And at 4 weeks in the first control, we saw good tolerability. The HIV viral load was below 20 copies in just 4 weeks. Remember that the baseline was 80,000 copies. The CD4 cells are now 240. They were 210. And at 6 months, the patient maintains a good tolerability and excellent treatment adherence. He remains with virological suppression. He is continuing to improve the CD4 cell count slowly. And you can see that the LDL cholesterol is 89, which is quite well. But remember that in this patient with a high cardiovascular risk, our target should be 70. So 89 is fine, but we should struggle to go below 70. So probably we'll have to increase the dose of atorvastatin. The HDL cholesterol is 41, and the body mass index, which was 24, now it's 26. We are in the range of overweight. 3 drugs were prescribed, gabapentin, trazodone, and omeprazole did not have a real indication in this patient and were stopped, and no new comorbidities developed in this patient. So what can we learn overall with this clinical case? Our final take-home messages. Antiretroviral efficacy is not compromised in older people living with HIV with any one of the currently recommended regimens. There are no specific recommendations regarding age or high cardiovascular risk in the guidelines, but probably they are not necessary because antiretroviral efficacy, as we saw, is not compromised with age. And with the exception of a boosted PI, all the other regimens have a similar profile regarding the lipids or the metabolic or the cardiovascular profile regarding the patient. We have to pursue a low risk for drug-drug interaction, so boosting agents not recommended in people with polypharmacy. In second, late presentation, as we saw, is common in older people. People, when they are diagnosed, usually they have a more severe disease, and it's very important to watch out any indicator HIV disease or any sexual risk practices, even in older people, because sometimes we have a low index of suspicion in the healthcare physicians and people get undiagnosed. Polypharmacy, as you saw, is the norm, And drug-drug interactions or inappropriate drug prescribing are common in older people. I think that they are decreasing, but it is still important to review it in every visit because the patient receives prescription not only from the HIV physician, but also from the primary care or any other physician specialist like the cardiologist or the neurologist or the urologist. So it's very important to review it in every visit every 6 months. Antihypertensive, antilipemic agents, and antidepressants, together with non-opioid analgesics and non-steroidal anti-inflammatory drugs, are the more common, uh, together with genitourinary agents, particularly in males due to the prostate enlargement. And finally, age per se is not a risk factor for weight increase in HIV or regarding antiretroviral treatment. Well, that was all, and thank you very much.